forward and not backwards, unfortunately. So you should go to the start. Sorry. I've heard that the live stream could not follow the presentation, and apologies for this. I was starting by saying that the burden of sepsis was poorly recognized given the burden that we hear. And this is a great step forward that we had 6 co-organizing organizations with great reputation around the globe. And this as such is an important step that we for the first time have had a side event alongside the United Nations General Assembly meeting. And as you can depict from the next slide, please, there are, and this is what I want to speak about, is why it's so important that we are here. Can you please forward the next slide, please? And this, and the next slide, please. Why is it urgently needed? And next slide, please. As you see, what Sir William Osler had set out already in 1900 was that humanity has but 3 great enemies: fever, famine, and war. And of these, fever by far is the greatest. And unfortunately, this is still true if you look at the numbers that are set out on the right-hand side. Most of the data on this is put together from our colleagues, and one of them will speak about it later also in a formal presentation by the authors of the Global Burden of Disease report. Next slide, please. And what you see on the next slide is, and this is from one of these publications, that this is also a big issue if you look at the incidence of sepsis in the US and Sweden. But there are countries in Africa, but also in Asia, Asia Pacific, where there's an incidence of sepsis up to 4,300 per 100,000 population. And this means that more than 85% of all sepsis cases happen in these regions. Next slide, please. And we need to make a difference and to change this. Next slide, please. Also, because this is not only an issue, next slide, please, for high-income countries, and because there has been made great progress, as you see, at the same time in 1900, the crude death rate, this is not the incidence in the US, has been 800 per 100,000 population. And it continuously decreased dramatically due to the fact that in 40 states in the US, departments of health was initiated. And there, along with this came better sanitation, came chlorination of water. This was only interrupted by the Spanish flu, as you see, in 1919. But later on, as you all know, development in progress against the fight against plague, the use of penicillin, other vaccines, etc., resulted in this dramatic decrease. But this was just in the US. And in those 85% of human mankind, this is not yet the case. It would be possible, and that's why we need, I think, the next slide, please, to make a difference. And we need also to make a difference because our hope that we have achieved in 2017, this sepsis resolution, which was an important milestone. However, unfortunately, also WHO have not made yet sepsis a priority in the same way how they have rightly made for AMR, for AIDS, for cancer, and World Sepsis Day is still not one of these 16 so far official World Health Days. Next slide, please. So we need to make a difference. Also because, which was rightly set out during the G7 leadership of Germany by our German Minister of Health, who committed in this communique in 2020 in Berlin that they will intensify to ensure the synergies in the fight against AMR and infection control and sepsis by national educational programs, and also they committed to boost the implementation of the requests of the WHO sepsis regulation on the globe. Unfortunately, these great proposals have not been taken up, nor by the Japanese G7 presidency, nor by the Indian G7 presidency. If you look at the number in India, so there's no other disease that costs more life than in this case. So next slide, and that's quite timely, and this was quoted in the New York Times on the occasion that the CDC has launched recommendations which apply for all US hospitals. And on this occasion, the mother of Rory Staunton, you know this story, has said, it's too late for Rory, but not for the 3 million others, and we are talking about the US, who are predicted to die of sepsis in the next decade, Ms. Staunton said in an interview. And so this tells you, next slide please, that behind this slide was a slide which did not appear up for, because the animation did not work, which would tell you that the number of sepsis cases in the US compared to breast cancer, prostate cancer, HIV, AMR is several times higher. So we have an issue which applies for high and low income country, and we need to make a difference, and that's why we, less than 2 weeks ago, in Berlin, we have adopted the Berlin Declaration, which aims to reinvigorate the fight and induce global actions on sepsis. So with this, I am in the end. And next slide, please. I will open and the first opening addresses and hand over to our colleagues and friends who are sitting together in Berlin, but not only in Berlin, to do the greetings according our program. And let me check who is the first, but he or she should be online already. It's indeed David, who is already here. David, please do your greetings on behalf of CHILD.
With pleasure. And I'll just open with the 3 most wonderful words one can use at the UN General Assembly: all protocols observed. I'll say I'm humbled and honored to welcome you all here to this event. I think honestly Clinton Health Access Initiative, whom I represent, supports the leadership of governments in low middle income countries to expand access to best-in-class health care at the same rate and pace as access in high-income countries. But I'm here as a stand-in. I think many of you will know that President Clinton was pretty open about the fact that he was hospitalized with sepsis a few years ago, and has deeply taken the issue of sepsis response to heart. He sends his deep regrets. This is probably the busiest week of the year for him. But I had the pleasure of speaking with him 2 weeks ago before our board meeting, and he sends both his best wishes, his apologies for not being here, and his emphasis that we resolve to address this critical problem. In a world where massive outrage and resolve led to the creation of programs including PEPFAR and Global Fund to respond to pandemics costing between 1 and 3 million individuals their lives in a year, it's shocking that sepsis, responsible for 11 million deaths per year, has not received that significant attention. If you're a donor or an implementer who's focused on improving outcomes in maternal and newborn health, you should be invested in sepsis prevention, diagnosis, and treatment. If you're a donor or an implementer who's trying to avert death from communicable diseases, including malaria or HIV, you should be invested in sepsis. I'm heartened to note that there are small steps being taken. Unitaid, a donor who focuses on improving access, has made investments in advancing advanced HIV disease care and has included severe bacterial infections, including sepsis, in that investment. Organizations such as GARD-P and CARB-X have been funded, arguably not to the level that they should be, but well funded, to aid in the development of new diagnostics and treatments for advanced bacterial illnesses. And Shinogi, in collaboration with GARD-P and CHI, is experimenting with the same type of voluntary licensing of a brand new antibiotic, which is the norm in HIV, malaria, and other care areas. But all of these technological advantages which are being developed are being delivered into a vacuum. There's no global fund for bacterial infections. Care seeking and treatment are fragmented across many programs, both public and private, where out-of-pocket payments lead to irrational treatment and care seeking, where it's cheaper to buy yourself a course of low-quality antibiotics than it is to actually get diagnosed with an illness with which you're affected. Stewardship programs, while well-intentioned, can come off as a systematic way to say no to treatment. We have our work cut out for us. Let us come together today and move into these sessions with urgency and focus, and let us also add to that resolve and resource. Thank you very much.
Thank you, David, for the true words and also the commitment to work with us jointly to synergize these actions. It's my pleasure now to invite Roland Goethe, who is a co-founder of the Virchow Foundation, and jointly with Detlef Ganten, they have invited us now also as Sepsis Foundation in Germany to work closely with them. And Roland, please give your address.
So we hope that you see us and hear us. So can you give us please a brief feedback? Hello, New York, here's Berlin.
We have challenges.
Das hat vorher funktioniert, ne?
Roland, if you can hear us, we're ready for you to speak. It looks from our screen like we may not have your audio yet. I'm not sure if that's an issue on our side or yours.
Hello, here's Berlin. Do you hear us now? It would be great if you could turn off your audio also. So, okay, I will try now. Maybe it seems to work. We hope that you hear us and see us. So, yeah, dear Professor Reinhard, dear Konrad, dear honorable members of parliament, Excellency Ambassador Dr. John Kengasong, dear David Ripkin, esteemed co-sponsors, ladies and gentlemen. First of all, I would like to congratulate the organizers of this tremendously important side event of the 78th United Nations General Assembly, and thank you so much for the very kind invitation. Considering that, as Dr. Mariam Yashi, newly appointed CEO of the Global Sepsis Alliance, has mapped among 560 events held at the margins of this UNGA, with 134 of them related to health, this meeting on synergizing global actions for sepsis, AMR, and PPPR for attaining health-related SDGs is the only sepsis-related discussion, and at the same time the only one of 5 events discussing AMR in connection to sepsis. And this level of importance of this event becomes very clear with that, as well as why this is an excellent and successful achievement of the Global Sepsis Alliance and its partners and supporters. And to you, dear Konrad, as well to everyone involved to make this event happen, greatest appreciation for your commitment in this regard and your crucial achievements in bringing the immense challenge of sepsis to this extraordinary visible level, an achievement which cannot be overestimated. And today we will for sure hear more about the medical and many other, also economic dimensions of sepsis and its consequences. There's no doubt, if we are really serious about the United Nations 2030 Agenda for Sustainable Development Goals, with its key target, SDG 3, Health for All, we cannot and we must not afford to not thoroughly and continuously address the enormously crucial challenge of sepsis with an annual death toll of 11 million. Rather, we must work closely and act coherently together to keep the fight against sepsis at the top of the national and the international agendas. As in other areas of achieving the health-related SDGs, the fight against AMR and sepsis can only succeed if we think and act across sectors, disciplines and borders and break down silos, and all relevant actor and stakeholder groups must be equally involved. Otherwise, we will fail to manage the absolutely necessary translation from strategy level towards implementation and tangible action on ground. When it comes to the most impressive role models of how to succeed on the strategy level as well as its translation to action, it is appropriate to highlight the inaugural Virchow Prize for Global Health laureate Dr. John Kengasong, Ambassador at Large, US Global AIDS Coordinator and Senior Bureau Official for Global Health Security and Diplomacy, and the previously founding director of the Africa CDC. In the spirit of Rudolf Virchow, the Virchow Prize for Global Health was established to honor significant contributions towards strengthening global health through lifetime achievements and long-standing engagement. It should recognize initiatives and achievements that not only address medical and direct health intervention, but also tackle the underlying cultural, social, economic, and political determinants of health inequities. And in this sense, John Kengasong, who will join us later, continues the legacy of Rudolf Virchow. And we are truly honored and delighted, every one of us here, that the first Virchow Prize laureate will enrich today's event on sepsis with a very special keynote. Concluding by underlining that with our non-profit Virchow Foundation for Global Health, we of course entirely support the critically important Berlin Declaration on Sepsis, an urgent call for the enforcement of the World Health Assembly Resolution 70.7 and reinvigorated global action on sepsis. And I'm very pleased to signal the same support also on behalf of the German Health Alliance, which I'm allowed to represent as well today. And just one sentence on that, GHA is a multi-sectoral initiative with its health system strengthening arm having been jointly established by the German government and the Federation of German Industries. But nowadays this initiative is a very heterogeneous mix of actors, and enabled by this heterogeneity, we can work in a systemic manner. And this initiative is comprising the expertise of 120 member organizations from private sectors, NGOs, science, academia, and development cooperation, and clear signal there's full support for the joint fight against sepsis. And being in this moment with Honorable Professor Andrew Ullmann, member of German Bundestag and chair of the Subcommittee on Global Health, and Dr. Mariam Yashi, here at the event and meeting room of the newly established Berlin Global Health Collective, together we are building somehow the Berlin backbone of today's crucial event in New York City. And while we are thus currently in 4,000 miles, almost exactly 4,000 miles physical distance to you, at the same time, emotionally and in terms of shared goals, we could not be closer. Wishing an excellent, most inspiring and very fruitful exchange. Thank you so much and cordial greetings from Berlin.
Vielen Dank. Dr. Niranjan Kisun, Professor Konrad Reinhardt, Evangelos Borbolis, Ruth Hecker, dear colleagues and friends. Sepsis accounts for nearly 1 in 5 deaths globally, and 85% of sepsis cases and deaths are in low and middle-income countries. Children under 5 years of age are among the most affected. But we know these deaths can be avoided through vaccines, rapid diagnostics, and timely access to appropriate and effective treatments. WHO is committed to addressing sepsis as a global threat. 6 years ago, our member states adopted the first global resolution on sepsis. This year's World Health Assembly adopted a resolution on emergency, critical and operative care, as well as a global strategy on infection prevention and control. Next year, WHO will launch new guidelines on sepsis prevention and management, including prevention of bloodstream infections. The challenge we all face now is to turn guidelines into action. So we welcome the focus of this year's World Sepsis Day event on implementing the WHO sepsis resolution nationally and globally. Thank you all for your continued commitment to the fight against sepsis as a global health threat and to promoting, providing and protecting health all over the world. I thank you. Vielen Dank.
Professor Dr. Konrad Reinhardt, President of the Global Sepsis Alliance, Excellencies, ladies and gentlemen, it is a timely moment to raise awareness of the global health threat posed by sepsis. This life-threatening response to an infection remains under-recognized. If not diagnosed early and treated promptly, it can lead to shock, multi-organ failure, and death. Indeed, patients who are critically ill with COVID-19 and other infectious diseases are amongst those at higher risk of developing sepsis and eventually dying from it. Known as the silent killer, sepsis kills someone every 2.8 seconds. Yet sepsis is not merely an issue confined to the health sphere. It is also a pressing development issue. Approximately 85% of sepsis cases and sepsis-related deaths worldwide occur in low and middle-income countries. It particularly affects vulnerable populations, including those aged over 60, newborn children, and people with pre-existing conditions. Indeed, reduced access to infection prevention strategies and resilient healthcare systems in developing countries is resulting in significantly poorer outcomes. We know that tackling sepsis is crucial to achieve the Sustainable Development Goals, or the SDGs. To achieve the SDG 3 targets, including the reduction of child mortality, and to expand universal health coverage, we must accelerate action to address the burden of sepsis in both high and low-income countries. With the recognition that most cases are either preventable or treatable if caught in time, the World Health Organization is leading global efforts to tackle the scourge of sepsis. That means acting upon the lessons of COVID-19, focusing on equity, strengthening health systems, and investing in prevention. As a foundation, hygiene is vital. We must ensure that everyone has access to safe and clean drinking water and sanitation. Notable progress is now being made. For instance, between the years 2015 and 2020, 107 million people gained access to safely managed drinking water at home. In addition, the United Nations is providing healthcare workers with vital skills. It is also informing communities on infection risks and the need to promptly seek care. We know that prevention is a first line of defense against sepsis. To this end, the UN family is working to ensure access to safe and affordable medicines and vaccines which reduce the risk of contracting infections. Look, for instance, to the work of Gavi, the Vaccine Alliance, which is supporting immunization programs in developing countries through public-private partnerships. Led by key actors, including the World Health Organization and UNICEF, our sister agencies, this work is ultimately helping to prevent millions of sepsis infections. The United Nations and its many partners are also working to strengthen health information systems and ensure access to rapid diagnostic tools. We also know that most studies of sepsis have been conducted in high-income countries. There is limited scientific evidence from the rest of the world. The global community must do more to improve high-quality data collection along with more research into treatments. We also need a renewed focus on sepsis prevention amongst newborns and on tackling antimicrobial resistance, an important driver of the condition. Professor Reinhardt, Excellencies, ladies and gentlemen, I would like to thank the Global Sepsis Alliance for their dedicated efforts to raise awareness and make sepsis a national and global priority. Indeed, contextualizing investments in sepsis prevention and treatment within the global movement around pandemic prevention, preparedness, and response is also a clear opportunity. Moreover, the new pandemic accord being developed has a vital role to play in tackling the conditions that allow sepsis to flourish. Finally, please continue to rely on the support of the United Nations family, UNDP, to deploy the latest science, technology, and innovation to stop sepsis in its tracks. Thank you so much for your work, your leadership, and let us hope that the world will quickly learn the vital lessons that you have been at the forefront of advocating.
Just one word before I hand over to Professor Lehmann, who is also a member of our board, on Achim Steiner, because he was the one who handed over personally a letter to Dr. Chan when she was Director General, just to letter from us, from the Global Sepsis Alliance and the task force of the Global Sepsis Alliance, where another member is present with Keith Martin, who will speak later. And his continuous support is really very important and encouraging for us. So Andre Ullmann, an esteemed colleague from Franconia also, where I come from, is a member of also the board of this Sepsis Foundation in Germany, and we are so welcome because he initiated, and from my understanding, this was the first parliament who created a subcommittee on global health, and this is, I think, a shining example which should be followed. Andrew, please.
Ladies and gentlemen and esteemed colleagues, I'm truly honored to address such a distinguished gathering of experts and advocates of global health. Today, we come together under a shared mission, a mission to make our world healthier, more resilient, and more equitable. The topic, Synergizing Global Actions for Sepsis, AMR, and PPPR for Attaining Health-Related SDGs, couldn't be more timely or relevant. We are at a pivotal moment in history where our collective actions can shape the future of global health. Sepsis, antimicrobial resistance, and the need for pandemic prevention, preparedness, and response capacities are critical challenges. Sepsis, often referred as the silent killer because not or too late diagnosed, claims countless lives each year. AMR threatens our ability to treat infections effectively, making even routine medical procedures riskier. And PPPR forms the bedrock of resilient healthcare systems, preventing illness and promoting well-being. But here's the inspiring part. By synergizing our global efforts, we can turn the tide. Together, we can find innovative solutions, share best practices, and build partnerships that transcend borders and disciplines. We can leverage our collective knowledge and resources to drive real change, all while advancing together the health-related sustainable development goals. As a member of the German Bundestag and the chair of the Global Health Subcommittee, I welcome the recent adoption of the Berlin Declaration on Sepsis. It is already signed by over 70 organizations from around the globe. It provides a new roadmap on how to reinvigorate the global action on sepsis. Germany has also played a critical role in the initiation of the historic 2017 World Health Assembly resolution on sepsis. But less than 10% of the UN member states have prioritized sepsis after the resolution. Therefore, more efforts have to be invested in monitoring enforcement of the resolution and even in working out a new resolution with more specific and measurable targets. Also in Germany, we have to keep sepsis high on the political agenda. Sepsis mortality here is higher than in other high-income countries, such as the US, Australia, and the UK. Therefore, we need to remain committed and take policy actions to improve the medical response to sepsis in Germany. And on a global scale, I encourage each of you to actively participate in this mission and to share your insights and to engage in meaningful dialogue. I also want to use this opportunity to thank all co-sponsor partners engaged in the organization on this first high-level sepsis side event. And I want to particularly express my gratitude to the Global Sepsis Alliance, the Virchow Foundation for Global Health, and the Sepsis Stiftung for their engagement. I look forward to strengthen our partnership and closely collaborate in the advancement of the sepsis agenda, not only in Germany, also together with you globally. Let's not just talk about change. Let's be the change makers. Let's identify concrete actions that can be taken, collaborations that can be formed, and policies that can be enacted to address this pressing global health issues. Remember, it's our shared dedication, our collective experience, and unwavering commitment that will propel us toward a healthier and more equitable world. Together, we can create a lasting impact on global health and move closer to achieving the SDGs. I look forward to new partnerships and ideas that will emerge from this event. Let's embark on this journey with enthusiasm, determination, and a shared vision for a healthier future. Together, we can make a lasting impact on global health and advance our mission to attain the health-related SDGs. Thank you for your dedication on this vital cause. I wish you all a productive and successful event in New York. And honestly, I wish I would be there with you personally to discuss all these issues that are so important for our world. Thank you for your participation and your attention.
encouraging word, and we may make a difference, because one objective of this meeting is also to get increased involvement of policymakers to make really a difference, and we are so proud that we have so far 4 members of parliament in our board. So it's my great pleasure now, and I mentioned already the unique role that Dr. Yasha, Mariam Yasha has had in terms of idea, but also of enactment and make it happen. And the same applies also for putting together the Berlin Declaration. Mariam, please.
So, distinguished delegates, colleagues, it's my pleasure to greet you on behalf of the Global Sepsis Alliance and to thank you for joining the very first meeting on sepsis on the margins of the UN General Assembly. I take this opportunity to extend our gratitude to the WHO Director General, Dr. Tedros Ghebreyesus, for his commitment that next year WHO will issue the guidelines on sepsis management. We are also grateful for the continued commitment of Achim Steiner, the UNDP Administrator and the Vice Chair of the UN Sustainable Development Group. And indeed, 2030 agenda, the success of the Sustainable Development Goals, will be much defined how successfully we can tackle the global challenge of sepsis. And let me summarize the reality that we're facing today. Our reality is that sepsis every year affects 50 million people. Every year, we're losing 11 million children, women, and men due to inability to prevent or timely identify sepsis. Sepsis spares no country, rich or poor, irrespective of the strength of their national health systems. As, for example, only in the United States, we are losing every year 350,000 people due to sepsis. And it's clear, without effective sepsis response, it would be impossible to attain the health-related sustainable development goals. And yet, sepsis is not visible in the high-level dialogue or the mainstream of the global health architecture. As already mentioned by my colleagues, less than 10% of UN member states are implementing and prioritizing national policies and initiatives on sepsis. And this is the reality that needs urgent attention. As the first step towards changing the current status quo, we have adopted the Berlin Declaration on Sepsis last week with 71 first signatory organizations as our international health partners. The Berlin Declaration is a new roadmap calling urgent action for UN member states, WHO, broader spectrum of public, private, academia, and civil society partners, and it provides a clear and realistic vision how we can reinvigorate the action on sepsis and how to use the unique opportunity of reducing the immense human suffering and economic burden of sepsis. The Berlin Declaration also reinforces the need for synergizing action on sepsis, AMR, the pandemic response, as without holistic and integrated approach, we would not be able to strengthen health systems at national and global levels and to attain universal health coverage or broader health development goals. I look forward to joining forces, working closely with existing co-sponsor organizations with Virchow Foundation, Clinton Health Access Initiative, the Parliament of Germany, Medical Women's International Association, Unite Parliamentarians Network, and the Global Antibiotic Research Development Partnership for implementing the new roadmap and restarting the global agenda for sepsis. I thank you for your attention, and we all look forward to follow the discussions from the Berlin Global Health Collective together with my colleagues. Thank you.
It's a pleasure to work with you. Sorry that we have some echo here, and also for mentioning that not only Unite but also GARC joined the Berlin Declaration, supported the Berlin Declaration, is supporting this meeting, which is again a signal which was unthinkable 5 years ago. And it's now my great pleasure to introduce our next moderator for the session on involvement and the role of the patients in this context, the president of the Women's in Medicine. Thank you for helping us, Eleanor.
Thank you very much. Welcome, welcome. Excellencies, ladies and gentlemen, I am Eleanor Wadinobi. I'm the president of the Medical Women's International Association and one of the participating partners here today. You are seated at a place and a time in history, the only panel on sepsis at the 2023 United Nations General Assembly as a side event. In Africa, where I come from, precisely Nigeria, we say, on a hot day like today, if you happen to enjoy the shade under a tree, spare a thought for those who planted the tree. And therefore today, I want to salute Professor Reinhardt. Thank you for planting the tree under which we find shade today as a pioneer and founder in the movement of the Global Sepsis Alliance and allies. I cannot continue without recognizing Dr. Mariam Jashi, the designated CEO, who has been acknowledged as having miraculously put this all together in the shortest of time. Thank you to all the collaborating partners. Thank you for those who are here in person and those online. Very quickly to tell you that the Medical Women's International Association, which is one of the partners, we have as our theme, one humanity, health solutions through partnerships, because we are indeed one humanity. When you know that 70% of the health workforce, frontliners, are women, think of the association that I belong to. I started my career as an anesthetist and saw firsthand in the intensive care sepsis-affected individuals. Friends, today is International Peace Day. There is no peace if you are unwell or if a loved one is unwell. And if that loved one or yourself has issues around sepsis. So as we remember World Peace Day, let's remember that if you are not in good health, you cannot think of yourself as being at peace. I had the opportunity to attend the high-level meetings on pandemic prevention, preparedness, and response, and today, universal health coverage. And I listened and I heard about the power of communities and technologies, how pathogens do not recognize geographies, do not recognize status. High income, low income, middle income, the pathogens that cause sepsis will cross those boundaries. I applaud the United Kingdom for Martha's Law. Martha's Law came about because of a young girl, Martha. And now in the UK, you can get a second opinion if you're unhappy with treatment. I have said enough. We have the experts in the room. We have erudite speakers who are going to talk to us about making sepsis a priority. And therefore, as your moderator today, I would like us to listen via Zoom to the first speaker, and thank you so much to those who are assisting us with the technology today. Dr. Moshen Naghavi is going to talk to us about the global burden of sepsis and its linkages to AMR and PPPR. I am seeing questions already about these acronyms. AMR, antimicrobial resistance, AMR. PPPR is pandemic prevention, preparedness, and response. So I've spelled that out for those who are asking questions online. Can we please listen to Dr. Professor of Health, Metric Sciences, University of Washington, Director, Institute for Health Metrics and Evaluation in Seattle, US. Are you ready, Professor? We are ready for you.
Thank you. Do you have my voice?
Loud and clear, Professor.
Okay. Then, if it is possible, let me thanks Professor Reinhardt and other friend from the Global Sepsis Alliance. And then, if you let me, I will start my presentation. I will try to be very fast and short. Okay, next slide. Okay, in 2019, we had 56 million deaths. For these 56 million deaths, 18 million was due to the cardiovascular, 10 million neoplasm, 3 million chronic respiratory, 3 million lower respiratory, and to the end. Next slide. In 2018, we started to gather data to calculate what is the number of the deaths with sepsis. And we gathered a big database. We ran a regression model. I do not want to go through all of them, this detail of the method, but we published this in 2018 in Lancet, and the method. And we find that, next slide. Next slide, please. Okay, we find that from these 56 million deaths that happened in 2019, 30.6 million die with sepsis. And sepsis is not just related to the infectious disease, that is blue line, blue part, is related to the non-communicable disease, that more than 5 million deaths happened in the by sepsis, in the non-communicable disease, in the injury, in the neonatal mortality and maternal mortality. Then these 13.6 million happen in all of the disease. Next slide. And you can see this is the fraction of the deaths due to the sepsis. You can see, as usual, rich country has a low fraction, low number, and poor country has a very, very big number. In some area in sub-Saharan Africa, in South Asia, you can see around 50%, 40% of the deaths is with sepsis. It means that situation is very bad. If we want to prevent, if we want to control sepsis, we have to prevent infections. Next slide. We started to find, okay, how we get sepsis when we have ischemic heart disease, when we have stroke, when we have road traffic injury, and we run, based on the data, our new model, and we find that 12 infectious syndrome are bridge between underlying cause and sepsis. Next slide. And these are distribution of the 12 infectious syndrome between underlying cause and sepsis. You can see UTI, bloodstream infectious, lower respiratory, cardiac infectious, diarrhea, meningitis. Distribution is completely different between different age group, but you can see the dominancy of infectious syndrome is by lower respiratory infectious and bloodstream infectious, and some other disease like diarrhea and UTI. These are TB. These are a big infectious syndrome that move patient with the underlying cause or with the healthy situation to the level of the very bad situation that is sepsis. Next slide. And this is one example. For example, you can see 9% of the people with stroke die with sepsis, and 42% of the people with cirrhosis die with sepsis, and COPD, and blah, blah. There is tons of examples. I don't want to go through that. Next slide. Okay, now again we started to gather data and put together around 460 million test culture, microbiology culture result, and we run a new method that is network meta-regression, and we start to find what is the pathogen by the different infectious syndrome that move person to the sepsis and deaths. Next slide. And we find that, okay, the biggest killer is Staph aureus, E. coli, Streptoneumoniae, Klebsiella, and you can see that we have this data. We have a VIS tool that is publicly available. Everybody can look to that with the name microbe. If you just put in the internet microbe AMR, it will come, and it has by country all the detail. And you can see that these are the bigger killer in the world bacteria that kill people. Next slide. Then after that, we started to check antimicrobial resistance for these bacteria for the different antibiotic. And also, we started to check what is the relative risk of dying with sepsis, with antimicrobial resistant, if with the pathogen, if you have resistant to the different bacteria, different antibiotic. In other words, we tested for 88 drug combo, what is the relative risk of dying with the this resistant if you have you got these infections. Next slide. And finally, we find, okay, in 2019, there was 13.6 million deaths due to the sepsis. From these 30.6 million, 8.8 million happened by bacteria. And from these 8.8 million, 4.9 million antimicrobial resistant was associated with deaths. What is the meaning of associated? It means that we cannot say 100% that these resistant was the causes of deaths, but infectious was involved in the deaths. Resistant was involved in the deaths. But from these 4 million, we can say 100% sure that 1.3 million died due to the resistance of the different pathogen to the different antibiotic, different bacteria to the different antibiotic. As you see, sepsis is envelope of the all type of infections that involve in the causes of deaths with the different underlying cause. And then bacteria is one part, virus is one part. We explained here just bacteria, and we explained other pathogen. We submitted the paper in the Lancet. Hopefully it will come. And it shows that how 88 pathogen kill more than 80% of the children in the sub-Saharan Africa, under 5 children. Next slide. And these shows pathogen, this shows drug, different drug, but combo, number of the deaths due to the associated with the different drug, but combo. First one is E. coli, aminopilin. Second one is E. coli and beta-lactam. Third one is blah, blah. It is just 40 drug combo. We have 88 drug combo that kill children, all age, rich people, poor people, but unfortunately kill children and poor people more than every other person. E. coli, aminopenicillin is one of the top drug combo that kill more than 760,000 deaths per year. It is much bigger than many other causes that we face in the world. Next slide. Okay, I hope that I finish on the time, and if there is any question or any comment, I will be happy to answer. Otherwise, in the end of the panel, if there is any question or comment, I will answer. Again, thank you for this time that I could share our result with you. Thank you.
Thank you so much, Professor. You can tell from the applause that we truly appreciated your presentation, and thank you. Please do hang on for us. We do have quite a lot of questions in the live chat. Now, we go on to our next presenter. With great delight, I would like to invite Thomas Heyman, President and CEO of the Sepsis Alliance, right here in the land in which we are today, in the United States. Thank you so much.
Thank you, Eleanor. A tough act to follow, Doctor, and you. And I think I have this right. It's an African proverb that if you want to go fast, go alone. If you want to go far, go together. And I'm so inspired by Conrad. Thank you, and thank you, everyone, that bringing us together, because we can't do this alone. It's way, way too big. Next slide, please. And I want to wish everyone a happy Sepsis Awareness Month. So we've been hearing a lot about numbers. They're big numbers, and the numbers just kind of go like this. They're too big. But it's about real people, and that's what our organization is about. We were founded by a dad who lost a daughter. Carl Flatley lost his daughter, Erin, who you see here. She was age 23, perfectly healthy, headed off to be a school teacher. That never happened. Carl was an endodontist, had never heard the word sepsis before. At that time, 2002, the CDC did not have sepsis in its work stream. There was nothing happening at CDC. Microsoft did not have the word in its lexicon. If you type sepsis into a Microsoft program, you would get a spell check error coming out of that. So Sepsis Alliance was formed out of a personal tragedy and a national need, clearly. We're the first organization doing this kind of work in the United States, and it was in 2010, about 13 years ago. We worked with some critical care societies. We realized there was a need to have a global organization that could help pull up organizations in each country around the globe and help them do this work. And it was in 2010 we were able to form the Global Sepsis Alliance. It was critical care focused, and we know now we really need to move upstream. It was great that the critical care docs and nurses were interested in this, but that's not where you want to be meeting sepsis. You want to meet it much earlier. Critical care, you're trying to save lives and limb. Let's move upstream. So we're an organization, patient advocacy organization, an NGO, and we really have been focused on partnering with industry, partnering with the clinical community, with the research community, with patient peer advocacy organizations. That's the only way we're going to get it done. Big interest in infection prevention, early recognition, healthcare-acquired infections, AMR, and health equity. As we know, we hear about this, people are interested in HAIs, and you say, well, why are you interested in HAIs? Well, infections are bad. But why? Why are you interested in preventing infections? They're not connecting the dots yet to sepsis. Same with AMR. They're not adequately connecting the dots. AMR doesn't kill you. Sepsis kills you. And I see we're running around the slides again. So there we go. Okay. Sepsis is a public health crisis. The numbers disproportionately in low and middle income countries, but a major problem here in the US, 1.7 million cases each year. So very, very common, very high mortality numerator, 350,000 perishing each year. That's just unacceptable. And as we know, it is the fatal complication of COVID, like it is to any other type of infection. Like stroke, sepsis is a medical emergency, requires rapid treatment, and in fact, sepsis is more common and more deadly than stroke. My neighbor, that was information to my neighbor. I know it's information to many of those out there. And most at risk, very young, immune-compromised folks, older folks, unfortunately, and medically underserved communities. Next slide, please. So here we go. We're number one, but not in a good way. Number one cause of death in U.S. hospitals. 1 in 3 people who die in a hospital in the United States is dying of sepsis. 6% of admissions, 35% of those who don't leave the hospital alive. How is that? Number one cost of hospital care and skilled nursing in the U.S. And the number one cause of readmissions. Fully 2 out of 5 people who are lucky enough to leave the hospital alive are back in within 90 days. Very high mortality rate post-discharge as well. 14,000 patients require amputations each year, including one of our board members. We don't know why. Why is this leading to amputations? Why is it leading to death? We have to prevent the infections, we have to meet it early, and we have to properly diagnose and treat. A majority of survivors have ongoing challenges: cognitive, psychological, mental, executive functioning, and maternal sepsis, the #2 cause of maternal mortality in the country. And in the US, maternal mortality is actually getting worse, not better, with sepsis not helping that statistic. Children obviously not out of touch of sepsis, kills more children in the US than cancer, and more children than anything globally, as we've heard. And then when it comes to underserved communities, Black and other non-white individuals have nearly twice the incidence and twice the mortality as white individuals. We can and we must do better. Next slide. So just a little bit about what Sepsis Alliance is doing to confront this problem. We work in 4 discrete pillars. One is public education. We know that 87% of sepsis cases are present on admission in the hospital. So this is largely occurring in the community. UTIs, dental abscesses, kids scratching mosquito bites, kids getting hurt in gym class like Rory Staunton. So we need to have an educated public. People need to understand these symptoms like they know stroke and heart attack. They know them very well. They need to know stroke as well, if not better. We also support survivors. We recently launched the Sepsis Alliance Connect, which provides support to survivors, family members, and those who have lost a loved one. And we have about 1,200 people participating in that community thus far, and we're just about a year into it. We also know that our healthcare providers do not have sepsis on their radar. They're not sepsis prepared. So we found this out the hard way through anecdote and through research, and with some funding from BARDA, we created the Sepsis Alliance Institute. We have now over 170 courses for healthcare providers across the continuum of care. We have a faculty of nearly 300 subject matter experts from across the globe, and we've trained over 40,000 healthcare professionals thus far. This is very, very scalable. When it comes to advocacy, this is where you can really make things happen. Sepsis Alliance Voices is our platform where we energize the voices of thousands of our patient community. We have thousands and thousands of people who are connected to us. Over 2,000 have shared their stories on our website, and they're ready to go. They're ready to go to talk to their congresspeople, their senators. We know where they live. We know what they want to do. We train them to be effective advocates, and off they go to make things happen. So we have 2 major initiatives that we're focused on right now. One is the creation of a national sepsis data trust, which could just as easily be a global data trust. Inspired by the cancer registries, which was such a game changer back in the early 90s, the creation of the CDC National Cancer Registries totally changed the game in terms of our understanding of cancer, our ability to define it more heterogeneously, help us understand it in terms of research, diagnosing it, and treating it. I just had lunch with a friend of mine, a bladder cancer survivor. Treated it very, very specifically, and he's doing great. 20 years ago, probably not. We thought of it as one type of cancer. Similarly with sepsis, we believe there's a heterogeneity to it that we really need to better understand. We're using blunt definitions, blunt diagnostics, blunt therapeutics, and as a result, surprise, we're not getting much of an improvement in outcomes. So we believe that the creation of a national sepsis data trust, aligning all of this patient data that exists, the hospitals don't own it, the people own it, it should be used for the purpose of improving care. We believe very, very strongly in this, and Mikey Sherrill, Congresswoman from New Jersey, is our lead sponsor. Casey out of Pennsylvania is our lead sponsor in the Senate. We're hoping that gets reintroduced within the next few days. National Sepsis Action Plan. We heard the WHO. We heard Conrad say the US needs to have a National Sepsis Action Plan. Last week, we called on the Biden-Harris administration to do exactly that. We're hoping to pull everyone together to make that a reality here in the US. It's just pathetic and unacceptable that the United States has not heeded the call from the United Nations, WHO, G7, and others to have a National Sepsis Action Plan in place. Last but not least, innovation. We know that there's innovation lacking when it comes to the prevention, diagnosis, and treatment of sepsis. We were asked by the FDA to form a collaborative community called the Sepsis Innovation Collaborative. It's funded by ASPR and BARDA, and we are working with those organizations and the CDC to identify opportunities to help us accelerate innovation when it comes to infection management and sepsis. We're about 2 years into that work. We have 100 members working with us, and we're really very excited about things that we can make happen. With that, I'll turn it back to Eleanor.
Thank you, and thank you again, Thomas, for sharing with us so eloquently those 4 pillars that the Sepsis Alliance built. Strong, formidable action pillars. I have the pleasure of inviting Shahzad Kervash, Ambassador for Sepsis Fonden, a sepsis survivor, speaker, triathlete, all the way from Sweden via Zoom. The floor is yours, Shahzad. Welcome.
Thank you very much. I hope that you can hear me. And as always, thank you, Professor Reinhardt, for planting a tree. And thank you so much for having me today. I would like to begin with shortly telling you my sepsis story. In 2012, I was a very happy and healthy 28-year-old. On what began as an ordinary Wednesday, I went to work and afterwards I went to the gym. I was strong and I felt very normal. But on my way to the locker room, I had this peculiar stomach ache, as if a giant worm was squirming around inside my stomach. A few hours later, I called the emergency number for the first time because I had chest pains. The ambulance came, I had rapid breathing and a heart rate of 144. Even though I practically begged them to take me to the hospital, they told me that I was having a panic attack and asked me to call someone who could keep me company. I called my little brother. 3 hours later, I collapsed on my way to the kitchen. My brother found me unconscious and my face had turned blue. Now I had a very high fever, still a very elevated heart rate, low saturations, and I also had spots on my skin. Meningococcal septicemia was my diagnosis. And the doctors told my brother to call our parents and everyone who wants to be by my side during what they believe would be my last hours. I survived, but at the expense of both my lower legs. The doctors had no other viable options than to amputate them. So there I was, at what was supposed to be the prime of my life, with no hope and no belief in the future. In some attempt to regain control, I returned to the gym, and there I met the person who changed everything, my trainer Kajsa. She suggested that I should participate in Sweden's largest triathlon competition. What is very relevant here is that I didn't know how to swim. I have always been terrified of water. I have only biked as a child, and I hated running, because that is what you do in a triathlon, right? You swim, you bike, and you run. But it was a really big challenge, but I had already lost everything. 3 years after my sepsis, I swam 1,500 meters, I biked 40 kilometers, and ran 10 kilometers. And I crossed the finish line as the first ever double amputee in Sweden to do so. The following year, I went on the biggest adventure of them all. I qualified for the Paralympic Games in Rio, and this time I crossed the finish line as the 7th best para-triathlete in the world. When I began to speak about my journey to audiences consisting of the public, but also healthcare professionals, it became very clear that very, very few knew what sepsis is and what the symptoms are. And to be honest with you, I had no idea either before I got sick. There was a severe void in knowledge, and my main goal became to make sure that no one goes through what I went through. I joined the Sepsis Trust in Sweden, and we have been working very hard to raise awareness, to fund research, increase patient safety, and to help create quality of life for sepsis survivors. So therefore, I feel very privileged to be alive and here today to represent and be the voice of those 50 million people who suffer from sepsis every year. I believe that there are many incentives to why we should address sepsis as one of the biggest and most important challenges of our time. Let's just have a look at me. I was in a medically induced coma for 13 days. I was in the ICU for 8 weeks. Admitted at the hospital for over 7 months. I have been operated on 53 times. And as long as I am alive, the Swedish healthcare system is obliged to provide me with prosthetic legs. Undoubtedly, I have cost a lot of money. The economic burden speaks for itself. But also, the grief and sadness that I feel for having lost my legs is a constant, heavy cross to bear. My family and friends, they have endured so much pain and worry. I was the one who got sick, but sepsis took so much from all of us. But here comes the big paradox. All of this could have been prevented. And mind you, I live in Sweden, a high-income country with one of the strongest healthcare systems in the world. And to this day, even here, we cannot secure adequate prevention, early identification, and timely treatment of sepsis. We have the data and the knowledge to what needs to be done. And I strongly believe that we have the obligation of saving many of the 11 million lives of children, women, and men who lose their lives to sepsis every year. Thank you.
Truly extraordinary from a phenomenal woman. At one point, you said you felt you had lost everything. But to hear the number of operations, 53, 7 months on admission, 8 weeks in intensive care, with something that others called a panic attack. Yes, disgraceful indeed. Thank you for sharing your story. Thank you for reminding us that there are 11 million who don't get to share their story of something that is 100% preventable. You have raised questions around the economic burden of sepsis. Indeed, as we are at a side event and the United Nations General Assembly is going on, those of us in the room, those of us online, the time is yesterday for us to get this message out. Thank you to all the wonderful comments online. They have been coming fast and furious, but I haven't seen any questions. So I will turn to those in the room. We do have our keynote speaker already here and waiting. We are over time, but I will ask very kindly that if you have a pressing question, kindly raise your hand and we will ask our erudite panelists online and in the room. We have Thomas to take your questions. Any question, please. Okay, it means that we're ready. Sorry, was I too quick? All right, so I'm now going to stand down my duty as moderator for panel 1 and now turn over to our keynote speaker, who is none other than Ambassador at Large, Dr. John Nkengasong who is the Ambassador at Large, United States Global AIDS Coordinator and Senior Bureau Official for the Bureau of Global Health Security and Diplomacy with the U.S. Department of State. Dr. John Nkegasong is also the first, the number one, the numero uno. In my language, Igbo, Nkizizi, which means one, first, of the Virchow Prize for Global Health. But who am I to introduce the keynote speaker when we have our tree planter here? So I'm going to turn over the microphone, please, to Professor Reinhardt to appropriately introduce our keynote speaker. Thank you.
I have nothing to add, just to say that for me, this is the Nobel Prize for Global Health. And again, congratulations to our colleagues who joined us from Berlin, Detlef Ganten, Roland Goethe, and also Professor Ullmann. They will continue, and also Mariam, to have this a future prize which is badly needed. And I welcome you now and thank you again to the stage to share your vision. And you have made up and decided to address actually the title of the whole meeting. Thank you for coming despite this very busy time here at the United Nations.
Thank you. Thank you, and good afternoon. What a busy time in New York. The UNGA is always a fascinating moment to be in New York. I personally look forward to being in New York during this week always, but also looking forward to leave New York because of the traffic jam. It's really. I start there because with the notion of a traffic jam in New York, because over the years, my 35 years in public health, I have come to the conclusion that global health and global public health find itself in a jam. We are in a log jam like the traffic we are struggling with in New York. We are in a traffic jam on global health in definitions. We are in a jam in practice. So the title of this session is Synergizing Global Health Actions for Sepsis, AMR, PPPR for Attaining Health-related SDGs. So if you look at what we are challenged at this inflection point we find ourselves, it's enormous. It's huge. I try to simplify it in global health when it's so complex. I try to break it down into not more than 3 or 4 pockets. And when I try to do that with the conversation we are having, I say, well, before I go to sepsis, what are the challenges we are seeing now in global health? The complexities of global health and the evolution. Just 25 years ago, we had no Gavi, we had no PEPFAR, we had no Global Fund, and you had no CEPI, and you could go on. I mean, even CHI, I don't think you have CHI. I mean, that was 25 years ago. And I remember vividly because As I said, I've spent 35 years in the field. All of that is good news, but we have to harness that and channel those institutions, that energy into solving what the three pockets of the problems that we currently have in global health, what are called syndemics, the rising rates of non-communicable diseases, the existing endemic diseases regardless of where you are in the world, and the emerging infectious diseases, including AMR, antimicrobial resistance, which is projected to be killing up to about 10 million people a year by the year 2050 if the course of action is not altered. We are now in an era of epidemics or outbreaks or pandemics, and that speaks to the PPPR. This week I've attended 2 sessions at the UN on PPR. I actually read a statement on behalf of the United States yesterday. COVID. We always said and reminded ourselves that there will be a big pandemic. I remember in 2018 in Nigeria at the African Society for Lab Medicine, I gave a talk in December, and I talked about, is the glass half full or half empty for us to prepare for the next pandemic? That was in December 2018. In my previous role as the head of the Africa CDC at that time. And in December 2019, COVID hit. It started off somewhere in Wuhan, and we were like, started off as a curiosity, like what is happening there? And CNN or BBC is telling us something happening out there. But in 22 days, 66 countries were affected. And fast forward, 20 million or above counting have died because of COVID or due to COVID. It has costed us about $15 trillion. And we are officially out of it, but it's still a threat out there, right? So I use those numbers to say that, to reflect on the jam we find ourselves in. Numbers, and I've reflected on COVID over and over. I said, if a pandemic that killed 20 million people in the world in 2.5 years costed that amount of disruption and trade and economy, the trillions, doesn't awaken us, shake us, to really look at that traffic jam we find ourselves in global health, to address all of what we are discussing today. What is going to wake us up? What is going to wake us up? I start there instead of addressing the issue of sepsis, which I'll come to later, because until we step back and rethink global health practice and definitions, we will continue to be challenged. I've come to the realization that it's not so much about the number of deaths that speak to sympathy or provoke us to action. After all, the number 1 killer in the world is the non-communicable disease, hypertension. Okay. So what can we do to harness the evolution of global health over the last 25 years with the institutions that we've all put in place, all well-meaning and all well-intentioned, to address the complexities, the syndemics of global health that we face? A couple of reflections. If we look at a disease that I'm very familiar with, which is the HIV, and many people are, see Renuka is in the room, and David and others, say, what propelled the actions that led to a massive resource input to addressing one single disease, including a PEPFAR program, the President's Emergency Plan for AIDS Relief, which I run, and the Global Fund? How should we be messaging the threats that we face? Sepsis affects people in the developing countries and as well as the developed countries. The story we just heard from the young lady from Sweden is very emotional, very touching. I mean, it speaks to how suddenly, and quite suddenly, any of us could be affected seriously by sepsis and just get ourselves into that. But what into that situation? But what defines whether you come out narrating that story or your story is told by somebody else is where you live in the world. If she was living, I would argue that if she was living in another country other than Sweden, somebody else would be telling her story, not her telling her story. We also have attention deficiency in pandemics, or what I call a faded memory in pandemics and outcomes. So we wish that that situation goes away so that we can keep on doing what we have been doing. Let me challenge you all, and we don't need to answer that question here today. Say, what has happened, what significant has happened after the COVID pandemic? In other words, what institutions have emerged, what bold actions have emerged after the COVID-19 pandemic. The pandemic fund was established and raised, the target was to raise up to $10 billion a year. We are around $2 billion. And far from the $10 billion a year. If you compare that with the 15 trillion that evaporated during the COVID due to trade and other economy, you say, well, couldn't we take some change from there and then throw it into this mix of global health and then address the issues that we are dealing with from a holistic way? So if we have to address the issue of sepsis, which is a threat to everybody, you heard the story from the young lady, very touching. She was very normal, energetic, agile until a certain point, and then she completely fell apart. And that could happen to any of us suddenly. There are a couple of things that I've reflected over the years driven by the HIV response. First of all is where this political leadership, political commitment, and political will action follows. It is that political will/commitment that turned the corner on HIV, nothing else. I said yesterday at the breakfast session that the HIV pandemic, the response to the HIV pandemic is a book that, if I wrote that book, the cover page would be From Hopelessness to Hopefulness. And the chapters in that book will be chapters that are not so good, some good chapters and some excellent chapters. The not so good chapters will be chapters where antiretroviral therapy is available for almost 10 years and massive section of the world doesn't have access to that. And about 12 million people die between the time from 1996 to 2006. 12 million people, and I'll add needlessly. So I use that number again to weaponize my argument that deaths don't necessarily mean a lot to people. We are not awakened by just the number of deaths. So if we say, well, sepsis kills 10 million people a year, we are not making a case. What should the case look like? So let me make a case for what we should be looking at. We have to have the right champions and activists and rally it around sepsis. That is what turned the corner for HIV. In 2000, we were in South Africa. That time, President Mandela, it was a very tense moment. President Mbeki was an HIV denier, and President Mandela had just left office, was an HIV believer. So how do you reconcile the two? I remember sitting in that conference room in Durban, and President Mbeki opened a meeting. President Mandela closed the meeting. And he said, his hero, this is President Mandela, is anyone who saves lives. So how do we build champions? How do we build champions and championships around sepsis so that you have advocates and activists? So that you have advocates and activists around it. Otherwise, there's no political pressure for people to commit to it. And if there's no political commitment, there's no good public health practice. I also said yesterday that a formula that I've come to believe in is good politics plus good public health action save lives. Good politics plus good public health action save lives. So if you look at it, the PEPFAR, the turning point for PEPFAR, of course, was advocacy, but was that political courage that President Bush expressed at the State of the Union address in 2003. He took everybody by surprise, grabbed the podium during his State of the Union address and said, today I'm going to launch a $15 billion it was $15 billion at that time. We've spent more than $110 billion, but it was $15 billion at that time. It was massive at that time, 20 years ago. That turned the corner. When politics, good politics, like the likes of Kofi Annan and Obasanjo take the podium in Abuja and walk up there and said, African head of states, wake up, HIV/AIDS is going to kill you and destroy you. Let's create a global fund. It's good politics. Good politics, driven by activism and championship, turns the corner in any of these affections. So until and unless we have that, around sepsis, we continue to talk about ourselves and talk through ourselves and talk with ourselves. The things that define us and enable us to address the syndemics are the things that we know. Is workforce, the right workforce. The young lady talked about the diagnosis, and I'll add misdiagnosis, because in many settings, and you heard the struggle that she had even in the clinical diagnostics, right? It started off with it's a panic. I mean, maybe you just have a panic attack, go get some rest and whatever, right? She said that's a misdiagnostics. I mean, it's that. So that means the workforce for public health and global health, we really have to look at workforce at multiple levels. When we think of workforce, the first reaction is, let's look at the doctors. No, it's the doctors, the nurses, the community healthcare workers that need to all be sensitized as to how to manage this. Second is the systems that we work with every day. The surveillance systems, referral systems, the digital systems. Digitization is the future. We have to admit that we have to live in the future today. And we also have to look at where technology, the AI is heading to. I think AI, we're still in that debating phase of, is it going to be a terrible, bad technology or not? But I just read a paper in the New England yesterday. I think that really gave me hope and believe that AI will be a technology that will, if exploited right in healthcare, can help us advance the field. Prevention and awareness. Prevention and awareness. The syndemics that are described all have a strong component of prevention and awareness. If you do not do the awareness, you just cannot diagnose. And if you do not, there's no prevention of this, a lot of the infections are preventable. And lastly, moving towards precision medicine, where genomics become critical and central to the things that we must do, both in public health practice and in clinical medicine. The ability to understand, take advantage of our understanding of the full genomes, human genomes, and matching that with how the disease patterns, I think, is going to shape the future of what we do in global health. So that brings me to the last point, which is financing. How do we finance global health? I started off with the traffic jam in global health, and I'll end there because financing is getting very, very challenging. We find ourselves at an inflection point where global public health is competing with climate change, is competing with food crisis, is competing with war in Ukraine. And if I see how much the world has rallied in amount of money that has gone into the war in Ukraine, and I don't have an opinion on that, I'm just thinking of what is it that we are doing in this time that we find ourselves as humanity, and what is the role and the place of financing global health. When public health fails, global health fails. And when global health and public health fails, clinical medicine suffers. Clinical medicine suffers. It's a direct relationship that exists with all three of those. And when all of that fails, global health security fails and suffers. There's no global health security in a vacuum. So the PPPR is meaningless unless you have good public health practice. It's meaningless unless you have good global health practice. So financing will continue to be a challenge. How do we unlock that? I've not heard during our stay here in New York this week of any major pledges around financing the PPPR. I've heard statements, very eloquent statements. And you could essentially summarize the statements into let's collaborate more, let's cooperate more, let's coordinate more amongst ourselves. Those are the statement. I don't need to read another statement at the UN. I think that is just the overall statement there. So let me end my remarks by saying that we should all commit ourselves as in the way we communicate sepsis, because I don't think it's even well communicated. If you go to a developing country, I just came back from Nigeria last week and had a series of meetings with the Minister of Health. I don't think sepsis is on his mind. He's telling me about malaria, where Nigeria harbors about 30% of the world malaria cases. And the minister will say, well, the first malaria prevention programs were established in Nigeria in 1948. And today we still have many, many children dying of malaria. That is my preoccupation. Tuberculosis is a big one. I'm trying to fight and end HIV/AIDS. You don't hear sepsis. So how do we turn that around and create a movement around that? That way it generates domestic financing. The global space in physical space in funding global health is shrinking, and is shrinking very, very fast. A program that I'm fortunate to lead called PEPFAR has gone flat funded for 10 years, level funded for 10 years. Still has a lot of money, supported where the money goes to 55 countries, but it's flat funded for 10 years. I just talked about the pandemic fund, which had created a lot of excitement, but is shot by 8 billion to the target. So we must be creative. The creativity will come from a partnership with the private sector. The private sector will help us to innovate and leapfrog to addressing some of those system issues that are listed, i.e. technology, workforce, AI. The private sector will help us, can actually help us and begin to redistribute the ownership of the burden of global health. That way it's not governments thinking and believing that they can solve all the problems in public health. Because as I said, when public health fails, clinical medicine suffers and global health security suffers. So let's develop partnerships with the private sector. We have seen cases where in the private sector up their game, the impact is huge. I remember my time at the US CDC working with Renoka, we launched Lab for Life initiative, and it was a very impactful partnership. It's complemented and supplemented the work of government, but it was so much needed there. So I think we should continue to explore our options there. So I'd like to end by just thanking you again for the opportunity that you gave me to share my reflection on global health traffic jam and how we can unlock that traffic jam to an advanced global public health practice and health security. Thank you.
Thank you so much, and I would like to underpin every word that you have said. But you have rightly stressed the importance of the understanding and awareness for a problem. And I wonder what your opinion is about the fact that undoubtedly the majority of COVID deaths are deaths from viral sepsis. And these 20 million, which you rightly mentioned, need to be added to this, what we heard, not only 10 million, but 13.6 million. And I wonder how we can convince the policymakers, because you rightly said, was it 50 trillion or so, what overall the pandemic cost, that it's not understood by the public, and this is due to the fact that nor WHO, that nor the United Nations, that nor a president of any country has taken the opportunity to explain and educate what is that sepsis is a final common pathway of almost any infection, including tuberculosis, including malaria, etc., etc. And that's why I was so shocked not to find a word in the G7 declaration from Kyoto, neither in India. And this will only change if policymakers, but also thought leaders like you and others use this word. And there are therapies which were, and this was underpinned by COVID-19, that you can reduce mortality by addressing the overshooting immune response, which is quite different from HIV. And as long as it's not understood and spoken out that pandemics, any pandemics from the history back, was a pandemic which has been deadly due to the very word, and it was already recognized by Hippocrates and described with a wording: if the body is cold outside and hot inside, the prognosis of the patient is poor. The British Army have in 1941 put posters to their soldiers: where Hitler's best ally, using blitz methods, having as his discredit more deaths than the joint German forces together, alias blood poisoning and septicemia. So there was awareness, and it was forgotten, and we have to reinvigorate it, and we can only do it jointly. So that is a plea, and that's why we came up with this Berlin Declaration. It is evidence-based. How come that our leaders not follow the figures that are out there? So it's preventable. And only when, and I agree, that we definitely, we need all the, you have been so kind to speak in our opening session of our last World Sepsis. What have been the success factors in the fight against HIV? The very same is true. And if we have now in Germany an incidence in a high increment around 3 to 100,000, but we have an incidence of sepsis also in high income front, it's 700, with not counting the deaths and the cases of HIV. So that's, to be honest, is how I read history and numbers. And we live in times of fake news. And if not, we are acting along what we won't be able to progress. Also convince finance ministers and others if we are not able to convey this. So this is my comment and my question. Perhaps what makes it so difficult to foster this understanding, including that the long-term sequelae from sepsis are identical with the long-term sequelae from infection. And it's a good thing of this pandemic was that all of a sudden, sequelae from sepsis or sequelae from COVID, which I attended, came to the opinion of policymakers. And these are all issues that we need to overcome in various ways. So I stop and thank you. But this is, I think, the kind of agenda we try to set out in this Berlin Declaration. And if we are not able to convey this evidence message, and if we would count the finances and add to it, so yeah, so that's I feel why I am so positive that people like you, and not only you, have addressed this, and the policy maker really need to make a policy. What would happen with this pandemic if the policy makers would not have stepped in with different ways? But and this holds true also for HIV and also for endemics, because still more people die from sepsis from other causes, as this is the case, has been the case for COVID-19. And this we need to, yeah, do it. So, yeah.
So, just some additional reflections following your remarks very briefly. I've been thinking of what my next career should look like, and after I retire, and I think I'm seriously thinking of doing a course in sociology and psychology of translating public health into action, because there's a whole psychology and sociology there when you talk of policymakers. Who are the policymakers? And how do we talk to policymakers? And what drives policymakers and make them focus their attention on an issue? And without doing the course that I will do in future, which is the sociology and psychology, there are two things that I think drive political and policymakers, which from my experience running the COVID response in Africa, every month I had to brief like 15 head of states. I mean, they'll put it there in the middle for 2 hours or 3 hours. I will brief them and whatever. And I'll do that with graphs, simplified graphs and whatever. The two things are sympathy and concern. Is our case enough to create sympathy? Which means it might not affect them, the policy makers and the political leadership, but they are concerned, they are sympathetic to that. Sympathetic to that is maybe David, but, oh, poor David, I will do something to help David and whatever. So, all they are concerned with that. The concern factor is, look, it affected David, it might affect me, so let's get this thing out of our way. Because it's a money thing. If you go to, just came back from Nigeria, and the numbers are telling me 90% of the government's money is used in servicing debts, and 10% is used in investment in the ministry. So if 10% is used in addressing social issues. So it will be health issues, roads, and everything with 10% of their. So at that point, you are faced with a choice of, is this really concerning? Or is this sympathetic? That I mean, if it's sympathy, I drop it, and then I focus on where the concerns are. And until we are able to present that in a way that says to the leadership that, look, if you don't do this, as the young lady said in that video very eloquently, that as long as she is alive, the government of Sweden or the taxpayer will continue to care for that, then you factor that into the economic burden that the country is having, that then you start driving sympathy and concern at the same time. So the point I'm making is that until I believe, and I'm not sure that I'm right here, that we are able to communicate in a way that drives that, it will continue to be a bit challenging for, especially given that the physical space is getting tighter and tighter every day. And I might be totally wrong.
I think you are completely right, because you're, as a Virchow laureate, Virchow 150 years ago said, the medicines, the doctors have to say what the problems are, but it's the policymakers and the anthropologists who need to find the solutions. That's why your idea that in the future, but I think it's mostly, it's also this, but it's mostly, it goes only with the economics and which will make a difference and to use this word, because the burden is only understood when at every place where it applies, we use this word. So thank you again so much for your contribution. And now we continue with our next panel, and it's my great pleasure to ask Dr. Again, David, to present his thoughts on the lessons to be learned on these pandemics, and then also the others, and we should be as short as possible, because we have been running out of time, and we might also jointly decide whether we should handle this, whether we should remain in some way formal, because we must not miss really some comments and also statements for those who have been working with us, and perhaps we shorten our statements and then discuss them, because it's so important that we get this out also in the internet, and that's why even if some of us both who are listening outside and sitting here are somewhat exhausted, I think it's worthwhile, because these discussions are so precious, and these people who have not yet spoken, like Keith and like Ricardo, and you should speak up, and also Ellen, who has been working hard in this area, both in terms of finances and convincing policymakers. We need to hear your opinion, and perhaps we combine this kind, merge these two, and so that's
I'll be very brief, because frankly, I'd like to hear from the panel that's going to tell us how we get the money to address this. And I'm actually going to drop a lot of the comments I thought about in advance, and I'm going to diverge, because I was really inspired by John. You know, I have a new hero, and you know, Sharzad, I apologize for butchering the pronunciation of your name, but you left me speechless. And I think I would add one additional thing to what mobilizes governments and politicians to action, and it's fear. Fear that the next news cycle is going to say that they've done the wrong thing. When we look at HIV patients made their problem the problems of the politicians, and resources were mobilized. And I think we need to take that lesson and lean on remarkable activists to bring this problem home to those who make decisions. And then, and only then, will we see action. I'll just add, HIV, very much the response is based on patients' right to care. And I know access to antibiotics and having no hesitation to use them is highly appropriate. I'm going to stop here and turn it over. Maybe can I just pass to the next panelist? So I'll pass to Jen, and Jen, maybe you can pass from there.
Great. Thanks so much, Dave. My name's Jennifer Cohn. I'm an infectious disease physician, and I'm the director of the Global Antibiotic Research and Development Partnership, or GARD-P. I'm also gonna try and be very brief. I had a couple slides. Maybe we can go to the next slide. Thank you. So I just want to point out that right now, I feel like in sepsis and AMR, we're stuck, especially in low and middle income countries, in this very much surveil and contain as opposed to respond and treat. And this is a huge inequality and an injustice, and we have to break out of this. I want to show a cascade of care. Now in HIV, we have these cascades of care. We're trying to get to 95% identified, 95% on treatment, 95% basically undetectable viral load, which is success. This is the cascade of care for people in South Asia, in 4 countries in South Asia, with carbapenem-resistant serious bacterial infections. About 1.6 million people in 2019, according to some calculations from the Graham study, had a carbapenem-resistant serious bacterial infection. And this is the number of courses of antibiotics that have activity against those types of infections that were procured in that year. 3% potentially got treated. And we don't even know what's going on here. How many people were diagnosed? How many people got on some sort of treatment? How many people made it to the health facility? We don't know the cascade of care for this infection. We don't know the cascade of care for sepsis. These are things we really need to invest in. We need to learn the cascades of care, and we need to figure out where there are those gaps and how to actually intervene in those gaps. And I think very importantly, again, we need to break the kind of chain between serious bacterial infections and sepsis. And that means we need to respond early. We need to have the access to the right diagnostics, access to the right treatments, and training of healthcare workers and awareness. So that's all critical. So I think that's all I really wanted to say. I had a couple more slides, but I'll skip them. And I will hand over to the next speaker. Thank you.
Thank you. Yes. Just going to stand over here for a second. I just want to, again, thank the organizers for this fantastic event. And I, too, am rather moved by Dr. John's words, and I couldn't have said anything better. I'm an infectious diseases physician as well. I am very passionate about global health, AMR, and sepsis, and everything intertwined on the heels of the COVID-19 pandemic. Being on the front lines, I think we have seen remarkable changes that our community has gone through, and it's rather unfortunate because we weren't really even out of the pandemic, and we saw the disinterest already start to happen with the lack of funding, the lack of infrastructure and resources, and people were still dying, and vaccines weren't even fully allocated, and it just showed, as Dr. John mentioned, that the number of deaths is not something that really gets sympathy, and it's really startling. But we do have to kind of pivot and figure out how we can really get people to make positive change. And we saw things that worked during the COVID-19 pandemic, and we saw things that didn't. And I think we really have to take those lessons learned. What we have seen right now is that we are in the most challenging of times. The population of the world is growing. People, unfortunately, are getting displaced at alarmingly high rates because of the conflict that is going on in the world. And because of that, they don't have access to healthcare, they don't have access to vaccines, they don't have access to food or clean water. And all of this is going to continue to snowball, and things are just going to continue to get worse. You factor in climate change on top of that, and we can see that although we went through a once-in-a-lifetime pandemic, unfortunately, there will be another pandemic that'll be here sooner than we can even imagine. With globalization of travel, urbanization of lands, climate change, deforestation, there's just going to be even more spillover and zoonosis, and we are going to see more pandemics, and we really need to be prepared, and we need to do more now. We really can't have amnesia with what we just went through. We really have to invest right now so that we can really prevent and be prepared. And I think a meeting like this is really the best way to get that going, and having all the key stakeholders here to really make change. We know that infectious diseases are responsible for a tremendous amount of death globally, and we've heard over and over again how sepsis really accounts for a large number of deaths worldwide. And unfortunately, I agree with all the speakers here that people just don't know about sepsis, and they don't know about AMR, and it's really not something that's concerning, and it is concerning to the rest of us that see it. I can't tell you how many patients I see on a daily basis that have horrible outcomes from sepsis, from AMR, and this is going to continue to rise. It's predicted that by the year 2050, the causes of death from AMR are going to exceed those of cancer. So these are alarming numbers, and we really have to wake up and pay attention now. And I think something that's really equally important to really mention and really focus on is viral causes of sepsis, as you had mentioned. You know, going through the pandemic, I again want to really reiterate that COVID-19 was a significant cause of viral sepsis, and those deaths are really unaccounted for. In fact, I can say that I was able to just publish my book on COVID-19 viral sepsis just a few days ago. So this is something that is really under-recognized, under-diagnosed, and under-treated, and so the time is now to really focus in on other causes of sepsis in addition to traditional bacterial infections. And viral sepsis is something that needs the attention now. Lastly, I'll just go into really quickly about vaccine preventable diseases and how that is on the rise. And again, that leads to AMR, leads directly to sepsis, and we need to invest in that now. Everything is really intertwined between national and global health, and what we can all do, how we can all come to the table and come up with solutions that are really going to make change and impact people. We saw, obviously, during the pandemic, the stark deficiencies in vaccinations nationally and globally. We do know that disinformation and vaccine hesitancy has been around far before the COVID-19 pandemic, but it got accelerated during the pandemic. When it comes to global health, in 2019, I think there's some estimates that over 200,000 deaths occurred in children from vaccine preventable diseases. So, you know, this is really alarming. And there's some data out of WHO and UNICEF that states that there's, 17 million children missed a single dose of vaccine in 2020. So, these are really alarming numbers, and we really have to work harder to reach everyone where they are. And it's always unfortunate that disparities just get wider and wider, because those who are most impacted, unfortunately, will have the worst outcome. They will have the more severe scenario with the infection. They will have a more severe infection. They will have worse outcome, more disability, more death. And unfortunately, it's always the people that are most disproportionately impacted because of lack of simple things such as lack of access to healthcare, to vaccines, to clean water, to food. And I think this is the time where we can really come together as a community to work on these challenges and make sure that we do meet those SDG goals. I mean, we're halfway through that timeline now, and I think we're very, very far from reaching a lot of those targets. So the time is now really for us to come together. And as Dr. John mentioned, I think, it's really putting that fear, getting those policymakers, and, really just talking about how can we really impact positive change from, as you mentioned, not today, but yesterday. That's when the change needed to be done. So thank you.
Thank you very much. I think this was very timely. And I would suggest, because we have a pre-recorded story from Sudan, which demonstrates that this is a country which was the first in Africa who already 6 or 7 years ago established a national Sepsis Alliance. And they addressed us like now with a plea that they would not give up, that they dedicated their World Sepsis activities about healing from this tragedy which adds to this burden by war. And that's why we have put them in the program here, but also more than a week ago. This is already available and will be available on the internet. And that's why I think we promise that we will bring it jointly with the other presentations in the internet, and thank them again, but don't listen to it right now, given where we are right now. And I think this is now the time to hand over also to Keith, because we must not only learn, and Ricardo, we must not only learn from HIV, but from the cancer people who understood, who asked in the 50s and 60s, understood that a disease needs to be transformed politically before it can be transformed scientifically. And they asked for a Manhattan Project. They asked for a moonshot to cancer. And they have made a difference. And that's why it's so important that you, with your experience, work with us jointly to achieve what I think we all agree, and to make it happen. And perhaps Keith, and I mentioned already that you have been very long time with us, and Ricardo, who really understood very fast and got it, and this means and convinces us that policymakers are not stupid. Then they read the right arguments and because they need to be re-elected. But I don't want to stop now, and perhaps if you make some short comments and then we have perhaps a joint final round.
Fantastic. Conrad, thank you so much. It's wonderful to be here. And we met 13 years ago in Long Island, I think, for the first. So I just want to really thank, it's hard, right, doing this work. It's tough. And Conrad, it requires leaders and doers. And so Conrad, I want to thank you from the bottom of our collective hearts, if I can, what you've done, what Miriam is doing now, what Marvin is at the back, works tirelessly. Marvin, thank you. Marvin, thank you. Bravo. And the whole team of what you have done for so long, because this is we know, right? To move the ball forward, you've got to not stop, right? We know this. So I'm just going to make a few comments if I could. If I could put up the first slide, please, or if I have a clicker here. I'm going to get right to the heart of the matter because of the challenge that Conrad has given us. How do we actually go to where we need to go and get stuff done, right, in this environment? How do we move sepsis up? And I think I'll do my best to tie some things in, and then Ricardo's he's going to do the better job and really make it all work. So if we could just go ahead to the next slide, please. One more slide. I'm going to whip through the first ones. Well, that's missed a couple, but that's okay. So if I just take a look at this document that you have if you're online, take a look at it online, the Berlin Declaration for Sepsis, right? This is what we have to do, right? We need to get the stuff done. So so take a look at it. I'm not going to go through it, obviously, but take a look at it, because those are our marching orders that we've heard. And what I want to do is really take a look at how do we get this done and how do we move sepsis in that space. Now, the interesting thing is if you get sepsis, right, sepsis is a barometer of the health of a health system and the social determinants of health, right? It is the barometer of that. So how do we make sure we actually deal with the structures we've heard about? So there's a few things that we need to, if we get the next, here are the three big things in the Berlin Declaration to paraphrase. Number one, if you go back please one slide. Implement the commitments that we're talking about. Commitments have been made, but we know commitments are cheap. Pledges are cheap. They're made all the time, and they're often not implemented. We're hearing that all week, and at every COP or every UNGA, the same thing happens. There's a lot of this and not a lot of doing. So we're going to make that happen. Let's see how to do it. The WHO exercises normative functions to support sepsis, expanding and mobilizing the partnerships. Next slide, please. So let's get to the politics of it. To get stuff done, right, there's actually really a few things we need to understand. And I find in our community global health community, that oftentimes what they tend to forget, particularly these big international meetings, is that the rubber hits the road, not at the big multinational events, but the rubber hits the road at the national and better at the local and domestic places. That's where knowledge is translated into action. That's where impact happens. That's where, as we heard from the doctor, that patient care is happening there. So the translation of knowledge and the implementation of what we know is going to happen at a local level, and then at a national level. Oftentimes we talk multinationally, but that's That's aspirational, but just has its benefits. Second, gaps. Where are the big gaps? In our work, often in low to middle income countries, where we've heard the biggest challenges are, is that the gaps, at the actual implementation, you've got to have effective ministries. Not only ministries of health, but what else do we need? If you can do water and sanitation, you've got to have public works, right? You've got to have good, importantly, finance ministries to manage the money. And I'm going to get to a point that Dr. Nkengasong spoke about in a second, because it's really important. How do we get the money? Effective human resources. We're working in a country in West Africa which has been devastated by war and Ebola, and obviously have huge mental health care challenges. I use this as an example. So if you ask the question, how many people in that country, how many psychiatrists do they have? They have 2. They have no nurses with mental health care training, 2 psychiatrists. So importantly, if that country wanted to implement their mental health care services, how many people in the Ministry of Health do they have to do that? 1. They're set up for failure. So one massive gap that we are not dealing with is to work with countries to help to strengthen up their public service, so they have the people and the training to be able to do this. And this is where an opportunity for academic institutions within countries are. Can we get academic institutions within countries to partner effectively with their governments to help to provide trainers and training to be able to accomplish that? At our organization, at the Consortium of Universities for Global Health, we created a platform to do just that. It's open access to everybody, easy to find. www.cughcapacitybuilding.org. cughcapacitybuilding.org. You can use it, please do, because that gives anybody, any country, any organization, the capacity to state your training needs, but also for others to state their training capacities. So look at it as kind of a dating service without the romance, right? We're connecting the training needs with the trainers, and you can use it. So please, I beseech you to do so. Infrastructure, we heard that earlier, right? Financing. Now here's where maybe Dr. Nkengasong and I might have a little bit of a thing. We go to the private sector, right? The private sector, it's important for us to understand that there could be and can be an important part of the solution, but their incentive is to make money for shareholders. It isn't to save money, right? Sorry, it isn't to save lives. But what we can do is frame that relationship in a way that speaks to their incentives, I think, so they can become a more effective partner. They're making a lot of pledges for a long period of time to do a lot of things, but they aren't rocking up to do them. So how do we partner with them in a way that understands their incentives and can align their incentives to make money with our interests in being able to save lives? And that's where government has to come in to be able to create those effective collaborations to be able to do that. But where does the money come from? If you look at official development assistance, it's about $157 billion a year. If you look at the money lost in corruption, $1.5 to $3 trillion a year, big T trillion, from the IMF, right? That's what they've stated. So the money lost to corruption is at least an order of magnitude of what we're doing for ODAs. So the money for doing this stuff isn't going to come from aid. It can come from countries stopping the hemorrhaging of the loss of funds, particularly from low-income countries. And they're hemorrhaging funds, and the money's stocked in our countries, high-income countries, where it resides. Different conversation. So in order to be able to liberate those monies and enable countries to have those resources, strengthen the public service, strengthen the infrastructure, and have those strengthen the independent mechanisms that have oversight, media, independent judicial systems, and oversight mechanisms, really critically important. Next slide, please. So finally, the power structures. Who do you engage with? Well, oftentimes our folks think, oh, we got to engage with the minister. But as Ricardo and I know, and I think all of you know here, right, what's the lifespan of a minister? It's pretty short. It can be a few months to a few years. But where are the folks that stay for a longer period of time and actually do the implementation? Those are the public servants, right? So it's important to be able to engage with them. Engage with the people in the President's and Prime Minister's office. They may not be really obvious, but they can have the power. So know who has the power and speak to them. Engage them. Develop relationships with them. Be friends with them, because they're going to be your best ally to get stuff done. Yes, speak to cabinet, but not only ministers of health, but make sure we speak to those ministers of public works, finance. They probably want, some of them want your help, right? And of course, speak to the politicians as Ricardo are recovering from that life. So, but also importantly, speak to the media, right? It's really important that you develop relationships to do so. Engage with the public. We're talking about informing the public, right? The public can move the political and democracy. So it's really important that we keep communicating with the public. Private sector and civil society and academia. And next slide, please. Finally, what do we do about communicating? Well, as we heard from that powerful story from the young lady in Sweden, right? We all were riveted, right? And we remember what she says. So tell stories. We have the stories. We've heard them so often at the Sepsis Alliance meetings. Tell those stories that you told, the powerful one of the young 22-year-old woman who died. We remember those stories. And keep telling those stories. When you communicate with whether politicians or the public or public servants, don't use the 150-page report. Use the no-clip rule, which means whatever you give them has to be on one piece of paper. If it needs a paper clip, it ain't good. So it's not useful. They're not going to read it. So the one paperclip rule, remember that, one page. It's got to fit on there. Communicate visually, right? You've got to, not only to move this, you've got to move this. The stories will move this, but you remember the visuals more than the wonderful paper that we often communicate in. Locally relevant. As politicians, you want to get elected, right? So let's frame what we need to do. With the evidence is there. We heard it earlier. Let's frame what we want to do in the local contest. Tell the stories, and give them the reason why sepsis versus the 100 things they have on their plate should be elevated, right? So show value. Show value in terms of money saved, lives saved, and as the Minister of Health in Singapore said yesterday, we're all getting older and we're not going to be able to pay for what we need, so we have to prevent these from happening. Public health is the solution. It's the runt of the litter in financing, but if we're not in the public health game to give, So my wife did an override with, so every time she calls me, Stevie Wonder comes up. Yeah, I think so. And and repeat. So I just really want to thank you very much, Conrad, again, for having the time. We had a short period of time. Please look at our website, cugh.org. We have a big conference coming up. We do lots of stuff. We want to work with you. We have 38,000 scientists around the world. We have a big virtual meeting coming up in October. We can put a sepsis quickly on there if you want. We can work with you to do that. We can drive it on and get it into it's an open access free for all to attend. So thank you, Conrad. Thank you to everybody. We at CUGH look forward to continue to work with you and keep up the good work. Thank you.
To take over and to wrap this up in some way jointly with the statements.
All right. Okay. Thank you, Conrad.
We have still on the program, but I think it's
Thank you so much, and good afternoon to everyone. Good afternoon. Oh, good, thank you. Okay, we need to wake up. It's day 4 of UNGA. I feel like a month has passed since I arrived in New York, but we need to keep the energy going, and I'm very happy to be here, Conrad, and it's already been mentioned, your power, your energy, now your amazing new CEO, which is very important, and it goes to show that you put your money where your mouth is, where your heart is, when you believe in the power of politicians, and you got someone who truly understands policy and the political landscape to help co-lead this organization with you and your amazing team. And so very happy to be here and moderate this session. I've been told that we only have the room until 6:30, which has already passed. So your team is very nervous. They're going to kick us out. So I'm going to be very quick. Moderating with such an amazing group of people is well, Keith, you all already understood, having been a former politician, a member of parliament, and of course at CUGH, an amazing leader in the global health space. On this panel, we also have my dear friend Alan Donnelly from G20, G7 Health and Development Partnership, but also a financial leader, an amazing politician. A rare case, if you want to take a picture with him, do. He was a member of the European Parliament, and he's from the UK. This is something that does not exist anymore. And beyond that, he's an amazing guy, amazing friend. And Unite and G20, G7 partnership has something brewing, which I think can be exciting. I won't say it. You can say it if you want. I'll leave it up to you. And also, and we also have, of course, online, Kiran, who many of you know as the founder of End Sepsis. We'll be hearing from him. And also Roland Good, who is also an amazing friend, president of German Health Alliance, and co-founder and CEO at the Virchow Foundation for Global Health, along with our dear friend Detlef Ganten. And so it's an amazing panel. But Connor, you asked me then to say how to convince policymakers, right? And saying that 11 million people die per year, more than all of COVID together, is not enough. They don't understand, right? Most people don't talk. You know, for me, this is a very sensitive issue, because I'm a physician by training. I'm trained in infectious diseases. The first 8 years of my professional life were in ICUs and infectious disease wards, losing patients due to antibiotic resistance, due to sepsis. Seeing those severe cases when nobody knew what to do with them in internal medicine anymore, we were the last stopping point. These were lives that were destroyed, young people. And you look at the tool case and the money being pumped into solving these problems when it comes to developing new technologies to address, it's not there. We're far from where we have to be. And then the innovative approaches that you were talking about, the clinical approaches, looking at our knowledge that so rapidly grew with COVID. We're not doing it in this field. High-level meeting next year is critical to hope change the narrative. But you know why COVID mobilized so many people to get a vaccine? Because it was the people in the global north that were dying. If it had been like AIDS, where it was mostly in sub-Saharan Africa, it would have taken us 20 years to get the medicines, as it did with the antiretroviral treatment. And we have a social contract in the world that's broken and that we need to fix. And we need to do this as a global community, and that is what global health, I believe, is all about. And you know, 4 terms in Parliament, many people ask me then, we've heard everybody say, from John to Keith, how do you convince policymakers, right? How do we actually get them to move? I'll give you my 2 cents on that matter. I use the ABCDE rule. A is awareness. If your constituents don't know what the hell you're talking about, your politicians are not going to do anything about it. So you have to make sure that the constituents are aligned in terms of the messaging. And that takes a lot of work. Sepsis is a word a lot of people don't know. And so this is something we have to do. B is budget. If you're presenting something, present it in a way that actually presents savings today. That's the most convincing argument. If that's not possible, then show a financial plan and explain where your money is, where the money to do what you are proposing is coming from. Because you are competing with dozens of people that are advocating for other things. This is critical. You need to provide, whoever's deciding, either the Minister of Health or someone else, a key in hand solution of how to fix it and explain step by step how you get there. C is cost opportunity. It was mentioned here today. If you do nothing, doing nothing is a political choice. And doing nothing has consequences. And this is something in politics we don't talk a lot, and especially advocates. Advocates always say, we have to do this, we have to do that. And nobody says, if you don't do anything, this is what's going to happen. And this is very important, I think. D is data. In showing that data, predictive modeling, now we have AI really in the horizon. Being able to present future solutions is critical. And to also understand that when you say we're going to save the world 30 years from now, for a politician, as Keith was saying, whose half-life cycle is 2 years, 30 years doesn't matter. If it's a 30-year outcome, then how do you break it down into yearly milestones. And it's possible. We can do that. And E, does anyone know what E is? Ethics is a good one. Anyone? Something very important. Nobody? This is the most important thing for politicians. Elections. Okay. Okay. So everybody tells me ethics or equity, all of them are important, but elections are extremely important. Make sure whatever you're doing, whatever you're advocating for, and the way you're presenting it is within the perspective of the political cycle, if you want to be effective, if you want to push for what you're fighting for. And so I won't take much more time because the time is short, but I'll leave it with the ABCDE for reflection, adding to what Keith said and what all the other, and John and so many others are saying. And I guess what we can do now is very quickly go through the speakers, and then if there are questions from the audience, we can do that very quickly. And so I guess we can go to Kieran, who's online, and I'll pass the floor to him. Kieran. You're on mute, Kieran.
I'm not sure if you can hear me or not. Someone put their hand up if you can hear me.
Just 1 second.
Can you hear me?
Hear you. Just 1 second.
Okay, we're checking. 1, 2, 3.
Kieran, do you have
Hello?
Are you on mute?
Hold on a minute. No, I don't believe I am, but let me check. I'm not on mute.
You're not on mute. Okay. Well, if you...
No, I'm not. No, I'm not on mute.
Yeah, okay, we can hear you now. Please, go ahead.
Okay. First of all, Marvin and Dr. Reinhardt, thank you very much. You've come to our city. But I also want to remind everyone who's out there is you're in one of the few capitals who actually have protocols, sepsis protocols, who are saving lives. Rory's regulations in New York State have saved over 20,000 lives. Someone earlier said about getting stuff done. That's one thing. As parents who watched our son die from sepsis, we believe from the very outset is we need to get stuff done. Urgency is now. It's not an initiative. It is what can we get done? How soon can we get it? There's no room for compromise with anyone when they say, well, we'll set up a committee and we'll look at it. When you're in the emergency ward with your dying son, a committee isn't any good. What prevents it getting in there is the protocols at the front door. From a national plan, what we have set up is a national initiative expert panel. We've had meetings with the federal agencies. We've got the financing. What we want to do is make sure there's an expert, there is a national plan, but first and foremost is saving lives. Because you see, when you look at stats and you look at anything else, when your child is one of those stats, it's very easy for people to compromise on issues when they haven't buried someone or bought a coffin. We spent a full weekend praying for our son to live and he died. Had he gone into a hospital up the road, he'd still be alive. So when someone says we look at it or we might set up a committee, and it's no. We have a template in New York called Rory's Regulations. We went right to the governor. We went right to the top. We didn't get a committee. We were offered many things and we said no. We want something that would save our child and save children. We have met with, we testified at the very first Senate hearings ever 10 years ago. We met with the CDC, and as anyone can tell you, we have been knocking on their door because they weren't doing much. They are now. It's taken 10 years. But as I said last year when we spoke, and it's 172 countries tuned in, is you have to make the first role. And the first role is to anyone who comes up against you saying, well, if this was your child, would you settle for that? Now, we have many initiatives going. We're in Ireland, doing a huge one in Ireland at the moment. But to what everyone has said out there is, action is needed now. Right? What we have done in New York is we've taken that graph and we've turned it the other way. It's nationally up at 350,000. We know what the international figures are. But it is not acceptable to say, well, we look at some reports, we look at committees, we'll kick it down the road. That's not good enough because you cannot kick a coffin down the road. So to everyone out there is, We have templates, we need to make them work, and this is a great initiative. Onwards and upwards. Thank you very much.
Can we get Roland on screen, please? Is he not online? Is he online? Okay, Alan Donnelly then.
Thanks very much. It's certainly been a long 2 weeks, hasn't it, this week? It's been extraordinary. So I'm Alan Donnelly. I chair the G20 G7 Health and Development Partnership, which is made up of the private sector, not-for-profit organizations, including TB Alliance, for example, Medicines for Malaria Ventures, and then also a big group of academic institutions. And we were established with the support of Angela Merkel in 2017 because she convened the first health ministers meeting. And, you know, during that meeting, she had a role-play exercise for health ministers on a pandemic, an airborne pandemic. And it showed that they were all completely unprepared, but nothing happened from it. Now, I want to be very, very quick. I mean, the evidence is very clear, and we're delighted, Conrad, that the Sepsis Alliance is part of this partnership. Next year, the high-level meeting will be looking at AMR, and in November of next year, the Saudi government will host the ministerial meeting on AMR. So I think what we've got to do is we've got to make sure that sepsis and the AMR agenda are linked together, and we need to start talking about it now to make sure it's linked together. So what are we going to do in the partnership? And I'm not going to make the announcement, Ricardo. We're leaving that for the Berlin World Health Summit. But Ricardo and I agreed last night that we're going to work very closely together on many of these initiatives. And the reason for that is, where's Keith? Keith, you were in the Canadian Parliament, yeah? Agreed with everything you said, by the way. I used to be the Labour leader in the European Parliament in the 14th century. Now, what we need to do is we need to look at the declarations that come out from heads of government. And we then need to have a look at the actions that they take. This is the critical thing. And there is a democratic deficit here. And the democratic deficit is leaders sign up to things at summit meetings and then nothing happens. And even when something happens, and I've spent some time with Dr. Tedros recently where we looked at the AMR national action plans, and we went through with his staff, are these being implemented? And I'm afraid for the vast majority of these national action plans, they're not worth the ink and paper or whatever it is now that they're written on. And so it's also about evaluation, it's about activation. So the thing that we're doing, and this is where, Conrad, we very much want the Sepsis Alliance to participate in this. We agreed at our H20 summit meeting in June at the, well, it was meant to be at the WHO, it was at the UN headquarters in Geneva, which is a horrible building. But we agreed that what we would do is we would appoint 2 rapporteurs, one from the Global North, one from the Global South. And so some of you might know these people. We've got Sarah Serdus, who you will know. Yep. And we've also got Christopher Kalila, who's from Zambia. They're both clinicians. And we're doing this in cooperation with the Commonwealth Parliamentary Association. The Commonwealth is made up of 56 countries around the world. And we've just appointed Agnès Buzyn, the former French health minister, as our global envoy for the partnership. And she did a lot of work when she was the French health minister on the issue of AMR and produced a report on it. Now, why is this important? We're going to have a series of hearings, and we will invite Conrad. We'll have one specific hearing on sepsis. And what we're asking these 2 rapporteurs to do is to produce a report. I spoke to Dr. Tedros, as I say, a couple of weeks ago about this. He will make an announcement, I think, around the time of the World Health Summit to back the initiative. And the report will not be, all the evidence. We know all the evidence. It has to be a very, very short report. As Keith said, it's got to be something that people will read. It's got to be a set of recommendations. But the other thing we'll do is we'll produce a model resolution. And Agnès Buzyn is arranging for me when I'm next in Paris to meet the Francophonie community, which is another 56 countries. There's a bit of an overlap with the Commonwealth. And obviously, because of my background as a former Vice President of the Parliament, we are working with the European Parliament as well, which is 27 countries. And the aim is to get these parliamentarians to raise the issues together, because they are very much linked of AMR and of sepsis. And I've given a commitment to Conrad, because he's been banging at me about this since we first met, and he's quite right, because we saw the statistics today. A large part of that report will also deal with sepsis, and we will be asking parliamentarians in their own parliaments to raise this with ministers. Now, why is that important? Well, I'm a former Labour politician, okay, so I declare my political colours. I was the Labour leader in the European Parliament. I hope we're going to win the general election in Britain next year. But the thing is that when Boris Johnson was Prime Minister and he chaired the British G7 presidency, included in the leaders' declaration was the need to increase spending on overseas development aid. And that was at the very time that he completely slashed the overseas development aid in the United Kingdom. So the point is, they agree to these things and they assume that no one will hold them accountable. And so the work that we're going to do together with Ricardo and with our partnership and with our global ambassadors, Renuka is one of our global ambassadors here from Chai, what we're going to do is we're going to try and hold these governments to account. And one of the great things that this partnership delivered in 2019, and this was thanks to the late Prime Minister Abe, who was a fantastic guy, he agreed, when we asked him, we went and met him, and he agreed to hold the first health and finance ministers meeting. And this was pre-pandemic. And I can tell you the most significant step that has been taken in terms of the debate on global health was getting finance ministers and health ministers together. Because finance ministers in their declarations now talk about investing in health as opposed to health as a cost. And so I'm really excited by this. The first hearing will be in November. Then we'll have a series of these other hearings. One will be dedicated to sepsis, and we'll consult with the Sepsis Alliance to make sure that we get it right. I'd very much like Kieran and some of the speakers we've heard today to participate in that hearing. And we will prepare, with these two rapporteurs and with Agnès Buzyn, short report and a model resolution for Parliament. And then we have to use all of our advocacy power between us, because we all have networks, to try and get parliaments to table the resolution. And there's all sorts of different procedures. In Britain, it's an early day motion. In the European Parliament, it's a motion for a resolution. It's probably different in the Portuguese Parliament, Ricardo. But what we want is we want these resolutions tabled, and the report will be ready, we hope, by the middle of March. So it will go to the World Health Assembly, but significantly, we will use it with health and finance ministers for the Brazilian presidency. And yesterday I met the Brazilian health minister, and I'm going to Brazil at the end of October. I met this morning, the Italian health minister, and we will work with the new G7 and G20 presidencies to try and move this. Next week I'm in Saudi Arabia, where we'll meet with the health and the finance minister about their ministerial meeting on AMR. And the aim is for me to say to them, please widen this so it includes sepsis. So, we're going to really do our best in the coming months to deal with that democratic deficit between what the ministers say and what happens on the ground. And your help and support, Conrad, and your colleagues and your new CEO will be very, very welcome in this process. Thank you.
Thank you, Alan. Very exciting things ahead, as we can see. And now, Roland, please, if we can get you on screen, please. Just 1 second, Roland, we can't hear you. For some reason, I don't know if you're on mute. Okay, give us one. Is the sound on here?
Hello. Hello. So the sound is on here.
Now you can't hear us? Can you hear us, Roland?
Hello, that's next guy from Berlin. Ah, now it's working. Okay. So I just hear the echo. Sorry. When my dear friend Ricardo is calling and making a wake-up call, of course, here in Berlin, 1 a.m., we wake up, so we are here. The technology will be stable now. So just very briefly, because time already run out, just a few thoughts at the end, summarizing also some important points. I mean, we have seen under the magnifying glass of Corona, and that was mentioned already, the extent to which health is directly interrelated with society, with politics, economy, climate, nutrition, and overall with stability and peace. We learned this, and this was dramatically brought into much sharper focus due to the pandemic. And in this context, policymakers, parliamentarians have both a role and responsibility at the center of the processes at the various specific pillars that provide healthcare, justice, equity, economic support, education, etc. And of course, at the very important intersection, overlaps and areas of interconnection, interaction. And therefore, we need political leadership more focusing on systemic strategies from a holistic perspective, while shaping with maximum transparency the corresponding policies and mechanisms and securing financing that was already well elaborated today. And that all embedded within the right and appropriate legislation. So quite a job, but this is needed. So overall, we need policymakers driving a consequent paradigm shift from health system strengthening to strengthening systems for health, by health in all policies. And that stands for all vertical pillars, but also for the horizontal of the health system strengthening. And just to mention the great work, Ricardo, you are doing with Unite and the International Forum on Global Health. So these are very significant milestones in this context, which we definitely need. I really want to be very brief. I just want to highlight another example where policymakers are really at the center, and they are so important. Thanks to Ricardo, there's a project, Global Health Policy Lab, which is a Harvard charity academic collaborative in order to making science and evidence-based policymaking a universal reality. And to reach this, to foster innovation and knowledge, to provide policymakers at all levels in all these different challenges with tools and competencies capable of accelerating the translation of what we have from the science to concrete laws, policies, etc. This is something where we really need this triad of policymaking, academia, and digitalization and artificial intelligence. And last sentence again on the financing. Ellen, you have made very clear statements and important statements on that. And I would like to add the really important work G20, G7 Health and Development Partnership is undertaking with the V4 Institute, because the best arguments, as explained already, the best arguments for politicians, for policymakers is besides, of course, the dramatic death toll of 11 million in the sepsis case, which cannot be, let's say, cannot be put on a balance to anything else. So that's dramatic enough. But what the politicians, policymakers need in arguments are, of course, on the financial side as well, looking to the long-term consequences of sepsis and sepsis, let's say, sepsis causes. So that needs common health metrics. So politicians need to be equipped with common health metrics, and G20, G7 Health and Development Partnership and WIFO Institute and Harvard University are working on this very important common health metrics to assess what does it mean if if governments invest into health. How can the impact on the economic growth, on the society well-being be measured? How can this contribute to resilience of health and the financial systems? So this all together, this is a big argument, important argument, and also a driver to achieve the SDGs. So I promise to keep it short. It's 5 minutes after 1 a.m. in the night here in Berlin. Thank you so much for your attention. And I just want to close with one LinkedIn post from Ricardo. As we are friends, I may do this. Just, I guess, 1 or 2 days ago, please, everyone look at LinkedIn, at Ricardo's account. There was a very nice picture when you arrived in New York. You were staying in front of a, I guess, Lego Hulk. It was a Hulk made from Lego bricks. And you put it very well, saying with this picture where you took a selfie, at the end of the day, you said, we are the leaders we have been waiting for, so looking for the superheroes. And I guess that's what we also look for, what we expect from the policymakers, and where we are standing on your side to support you and to go together to reach our shared goals. Thank you so much.
And in all honesty, we are the ones we've been waiting for. Is not my sentence. That was a quote from President Obama, but it's so true at every moment of history. We cannot wait for another generation to come to solve the problems. We have to solve them ourselves. And that is, I think, what is the main call out of this room. We cannot wait another generation. We cannot continue to see this death toll. So Conrad has been kind enough to ask me and Miriam to close this session. And I'll pass it to Miriam just after saying that we had a very passionate day in terms of speeches. We heard a lot of that is being done also on the research front, the investment front, also in terms of identifying the needs in this front. But then we also saw the human side of sepsis, those that lost their loved ones, the physicians, the healthcare workers that struggle with not having what is needed to address the challenges that they face on a daily basis, the health systems challenges within in terms of lack of organization and lack of orientation, of having disease-driven models that continue to rise the burden of disease instead of focusing on saving lives and focusing on health and well-being. We need to fix this broken model. And that is, I think, one of the greatest challenges. And sepsis and AMR, as Alan, I think, well put it, are interconnected, and we have a huge opportunity with some key moments over the next 12 months to truly put the world on track to end sepsis as the threat it has been over the years. And so I truly thank you. Just to say that on behalf of the Unite Parliamentarians Network, it's an honor to be part of this. And we will continue to work together to get those policymakers you've been calling for to do their job, which is to save lives and help the people in need. And to close, my dear friend, for so many years, and who deserves all the trust and confidence to lead now this amazing new initiative from her side as the new CEO designate, Maryam Jashi. I've seen your passion as Vice Minister of Health, as a Member of Parliament, as part of the UN system, and now in this new role, you have an easy challenge, which is to solve sepsis and get rid of sepsis as a global health threat. We're counting on you to do that, and what I can say is you're not alone. You have many friends here to make sure that you are successful on your journey. The floor is yours. Thank
you. Ricardo, I cannot thank you enough for all those words. And one that I can definitely repeat is that I know I'm not alone. I know I have a lot of friends, including you, Roland Goethe, just sitting next to me at a very late connection from Berlin. And without the support of Unite, Virchow Foundation, Clinton Health Access Initiative, Medical Women International Association, the Global Antibiotic Research and Development, and the Sepsis Stiftung, this meeting would not be feasible. We made a pretty ambitious goal of organizing within 7 months, 7 weeks period, the very first sepsis-side event on the margins of UNGA, and today's meeting with brilliant speakers could not be a better motivation and proof that we have friends and colleagues who can make a difference. Sepsis is a very clear cause. The data is clear, the evidence is available. There is no other single health cause in the global health architecture that has such an impact and such a potential to bring the better good to our societies, both from human and economic burden. And I look forward to joining forces and to implementing the Berlin Declaration and our restarting of the global health agenda in very close partnership with you. Special thanks to Investment Kingasong for taking time and being with us, and thanks for Virchow Foundation. I would like to thank Ellen Donnelly, who just shared with us the extremely important information. And of course, we will be communicating and coordinating very closely. This is extremely encouraging. Today, speaking about the synergy of sepsis and AMR is the best outcome and a very concrete outcome of our very first meeting. And I really hope that next time when we come to UN, next time when we come to the World Health Assembly, we'll be stronger, our voice will be stronger, and the eventual impact on policies and programs would be definitely effective. I would like to thank everyone, Keith Martin, Siren Staunton, who has done so much together with Orley Staunton for the US and globally. I can't list all the speakers, but please accept my deepest appreciation for your support, and I look forward to very closely working with you and really make a difference that will be impactful and hopefully not too long from today. Thank you. And of course, with my closing statement, it's an immense honor to have the opportunity of continuing the foundational work of Professor Konrad Reinhardt. Without him, we would not be today, and without his leadership, we would not have the World Health Resolution and all the wide-scale partnership and movement of the global response that we can continue and build on. Thank you very much, Konrad.
Again, we thank you so much. And it's, you see, there was a time where I was in sorrow on how its movement will continue. But now I'm for sure that we will make it, given this people, these organizations who come together. And this encouraged me still to believe in truth, in scientific data, and also in our political systems. So this is a system issue. And I stop here now, just agreeing again with a proposal by Miriam at the very end that you all should come forward and to have a photo as a group, and yeah, stay on, and we will group around the two of you, and so that I think is a great end, and thank you so much for such a great day. And next year we should not be along the United Nations General Assembly. This topic needs to be a topic of the United Nations meeting. And I also thank the listeners, the numerous listeners who have joined us online, not only in terms of telling these encouraging studies, but also for their interest. And I hope very much that they learned what they can and need do with our ongoing support in their countries, in their institutions, and in their communities.